So kind regards from tiny Luxembourg, because I'm sitting here in tiny Luxembourg, and I will share you my experience with the rehabilitation of the compromised maxilla using the Bone Truss Bridge approach. So here's some about my person, my studies, and my qualifications. So actually I work and I live in Luxembourg. And I started working on my project in 2014 already by designing this specific implant, which is a pterygoid implant, a very specific one to adapt to all difficult bone situations. I do publications in a regular way. So here's kind of my publications, and mostly is about the atrophied bone and how to do rehabilitations by using pterygoid implants. So now, what are the options were available for treatment, to treat a bone that is compromised, and how to treat it? So you may either adjust the anatomy to the implants, or you find the implants matching the anatomy of the patient. Adjusting anatomy, you see you have the calvarian grafts, you have sinus floor elevation, you have lateral crestal split, you have iliac bone grafts, you have nerve displacement, or you have here like this. You see that is a little bit more brutal, you see, but that for instance is a golden standard in Belgium to harvest bone from the skull. So also this is so an option, but it is not so minimal invasive. Or here you're taking out bone from the skull, or on the other way, you are modifying your implants. It means you are looking for implants which are matching the situation. So you have zygomatic implants, you have Hollande-4, you have trefoil. So zygomatic implants, you see another way which are quite invasive. You see, of course, it is an option. You see the implants in place. Or you may also actually work by CAD/CAM. You take subperiosteal implants. Or you're looking for one-piece tissue-level implants, and that is implants which I will speak about. You see they're thin and long, and you have different diameters, and you have different lengths in order to do rehabilitation. And I speak specifically now about the BTB protocol, or the Bone Truss Bridge protocol. So what are the principles of the Bone Truss Bridge? So the Bone Truss Bridge is a dental implant technique inspired by the architectural bowstring truss bridge. In a traditional bowstring truss bridge, a curved arch, the bows is connected by a straight beam, the string, with diagonal supports to ensure stability and distribute load effectivity. So this is done in 1841 in the States. And similarly, the bone truss approach strategically placed dental implants, including those in the pterygoid and transnasal regions, and they are acting as a supporting structure of full arch prosthesis in patients with severely atrophied maxilla, so in the upper jaw. And this approach is designed to distribute forces efficiently and reduce stress on the individual components. Michael, thank you. Just one moment. So we have here. Sorry, just one moment. Okay, so coming to the protocol, you see here, you have the traditional architectural bowstring truss bridge. And here, I was inspired by this bridge here in Luxembourg, you see. And we have also trademark registered in the UK. And then, in what ways does the design of the implants utilized in the Bone Truss Bridge method enhance its effectiveness? You see, in the BTB approach, the implants typically utilized are one-piece tissue-level implants that feature a bicortical anchorage. And they are specifically designed for narrow ridges and cases with atrophy. And these implants possess a tapered body and compressive threads, which contribute to attaining a higher degree of primary stability necessary for early or immediate loading. The implants also feature a multi-unit head that assists in addressing angulation challenges during the prosthetical phase. Additionally, they are constructed with a screw-type fixation to enhance stability and facilitate retrieval. The technique is specially appropriated for individuals with significant maxillar atrophy, and such patients may consider conventional implant procedures like bone grafting or sinus lifts to be overly invasive or lengthy, and they often seek a more straightforward and faster treatment option. So here, let's see the mathematical or engineering approach. So the Bone Truss Bridge is a biomechanical deconstruction, engineering rigid fixation in the atrophied maxilla through geometric triangulation. So we are decoding the architectural logic behind the implant positioning, and by treating the maxilla as a landscape and the implants as infrastructure, we uncover how the Bone Truss Bridge approach bypasses biological limitations to create immediate load-bearing stability. So the landscape, a structural deficiency of the atrophic maxilla. So we have the atrophied maxilla, and we are limited by big sinus and no bone. So, and the pivot is to achieve stability without bone grafting, and we must by this abandon vertical reliance and adopt the truss strategy, distributing loads across a wider multi-vector framework. See the engineering principles, the truss versus the pillar. See this in the traditional approach and the bone truss approach, and another time the goal is to create a rigid, immobile lattice capable of withstanding immediate loading forces. And the blueprint is inventory of the arch. You see, in general, we are trying to get 8 to 6 or 6 to 8 implants in the different angulations. And you see how we are going. So we have the anterior block. So the premaxilla typically retains the most bone volume still. And the image shows here 6 implants placed relatively parallel to each other. And you see the engineering logic is by grouping 6 features in the anterior zone, we create a solid compression block that anchors the front of the bridge truss. And then here you see the posterior distal angulations. And here the power of the triangulations is at the end of the result, where the prosthesis does not just sit on the implants, but it is structurally wedged against displacement by the opposing vectors of insertion. So coming to the posterior maxilla, you see mostly we have a big pneumatization, resorption of the bone crest, and the low density. And then the implant, which is our goalkeeper, let's say, speaking in pigs, you see it is an added value, yes or no? Of course, it is an added value, and you see there are a lot of publications also in the States. It is very famous. So you need, and you see also publications in PubMed about this anchorage. Here you see the zone, the posterior maxilla, and then the area where we want to put our pterygoid implant, the wings of the sphenoid and the pterygoid plates. You see here in pink is the nose, and you have the middle pterygoid plate where we want to anchor our implant, and here we are in a strong cortical anchorage. Here is the target, you see, the medial wall of the pterygoid plate. Another time here, we are going to the maxillary tuberosity, to the pyramidal bone, and to the medial plate of the pterygoid. Another time here, you see another perspective in the angulations and how to place this implant. Let's come see some cases how this may work. You see big atrophy in the maxilla, a young patient, 45, how to do in a very minimally invasive way. So we are doing bone flap, we are doing our verification jig, and here you see already 3 weeks later our patient is finished and he got a metal acrylic bridge after 2 weeks. And here you see we are staying out of the sinus, so minimally invasive. We are checking the bone, and we are anchorage there where we have a strong cortical bone, strong anchorage, and you see it is minimally invasive. 4 years follow-up in June, all is perfect. Or another case, a 63 years individual, you see he wanted just to eat. Another time, extractions were carried out. After the teeth extractions, no bone. And then we are doing bone-driven implantology because we are putting our implants where the bone is. We are doing this impression immediately after surgery. You see our implants. We are long implants, 24 millimeters and diameter of 3.5. Impression without a tray, immediately model and try in. And also here, 3 weeks later, we have our patient finished and he's very happy. A 3 years follow-up, and you see the X-ray. So you see long implants in an oblique situation, and this is then the Bone Truss Bridge approach. Another finished case, so this was finished after 3 weeks. Another young patient, 40 years young. The lady, she was very unhappy. She had also very narrow ridge. And another, here you see the narrow ridge. We do a palatal approach and also nasal floor exposure and the nasal floor elevation in order to put these implants, impression, meeting, temporal bridge, and the different steps. You see, she was very unhappy because she had a total prosthesis with a lot of glue. And then here you see we could deliver in a very short way. Another time, these one-piece tissue level implants were used. We are taking here a resin bridge, and you see happy patient all the years later. And here the day of placement, 3 weeks later, early loading. And here we did then also the mandible. The mandible was done also by immediate loading, and here we will plates in the posterior area with it. Another young patient, 48 years young. You see there was no bone, but there was bone to put our good implants and to get our nasal approach. You see, we are opening the nasal floor, we are putting our implants, post-surgery, so impressions immediately after surgery, without a tray. You see here on the model, no bone, nothing, very flat. And then here, also 3 weeks later, we could put our prosthesis, placement, all is screw retained, and another happy patient. And you see all these different angulations. And then, of course, you need to have a lab who is capable to do such job. Also, we may work in different way using metal ceramic, like here. So there was a little bit more bone, so having more bone, we can go for metal ceramic. So the extractions are carried out, implants placed, impression after surgery, our verification jig, and here the finished metal ceramic bridge delivered then also here 3 weeks later. See the soft tissue already is a nice healing, and here the finished result. I think the patient was very happy before and after. And here you see another time our Bone Truss Bridge approach. We are putting our implants, strong cortical anchorage, and we can go for direct load. A nice pic here to see. This lady, you see, she wanted to remove out her teeth on the right side. So here, seeing all the gap, big infection. And here you could see this approach. Here on the left side, she got a traditional sinus lift, and the treatment time was around 1 year. And by the Bone Truss Bridge approach and using our implants, asserting them in an oblique way, we could finish the treatment metal ceramic after 3 weeks. So having long implants, thin one, you may screw, you get an osteofixation, and having this osteofixation, you had a strong anchorage and you may go for direct load. Long implants, so you see the placement here. You see the big damage here in the bone. So we full fit the here with graft material, and also here it was impression after. You see the model and the verification check, and immediately here also we placed a metal ceramic bridge after 3 weeks, and then you see here's the result, and the patient was very happy. So of course you see if a patient has a choice between one year or 3 weeks, I think you know what the patient will choose. So here's the message to take home. So if you have a narrow ridge with adequate bone height, enabling long implants for higher torque. You may do a compression and early loading. Digital workflow also is possible. So also this is depending from the colleagues how they want to do. The way by analog is you see when you do it after surgery, it will work. So it will a perfect protocol. Digital, sometimes it is a little bit more tricky, but of course everything is there to do also a digital workflow. And yeah, so the patients may choose what they want to do. So I give then with my colleagues a regular training in the UK or in Spain, and we are doing this mostly on cadavers, on fresh frozen cadavers, where the doctors may train. And you see here that is a freshly frozen cadaver head, looks a bit nice quality, and by this the doctors may train and they may become master in this. So you see, if you want to get trained with our academy, you see here our website, and you see predictable outcomes and minimal invasive. So our next training will be in Spain and then in the UK. And then that was it. So thank you very much for your kind attention.